Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Our purpose in this presentation is to demonstrate the fabrication of the orthodontic Facebow appliance. The Facebow appliance is sometimes referred to as the headgear appliance. It consists of two maxillary first permanent molar bands with a buccal tube welded to place on the buccal surface of the molar band. Also a wire Facebow, this is the actual Facebow itself, that fits into the buccal tubes on the first permanent molars and extends outward into the outer bows. And usually it also involves the use of a neck strap consisting of elastic stripping and a foam rubber pad that fits against a patient's neck. This is the cervical pull Facebow appliance. Here's a picture of a child with the cervical pull Facebow in place. This type of Facebow appliance is the most commonly used clinically. Forces are applied through the Facebow wire to the first permanent molar by the elastic neck strap. Returning to our model, the other commonly used Facebow design is that of the high pull Facebow. It consists of the same intraoral components, the first permanent molar bands and the Facebow wire itself, but for its anchorage unit it involves the use of a strap head cap assembly and elastic rubber bands to apply the force to the Facebow and ultimately to the first permanent molars. Here's a picture of a child with a high pull Facebow in place. The top and back of the patient's head serve as the anchorage for the appliance. The posterior superior direction of force of this appliance causes and distal and intrusive movement of the first permanent molars. The type of Facebow, cervical or high pull, that's used in a particular case depends on the characteristics of that case, the class of the malocclusion, the depth of the overbite, the crowding or spacing that's present in the arch, and plus many other factors. Regarding the clinical use of the appliance, in interceptive orthodontics, the Facebow is used to move the first permanent molars to the distal after they have been drifted mesially due to premature loss of a second primary molar. The Facebow then is a bilateral space regaining appliance for bilateral distal movement of the first permanent molars. The Facebow appliance is also used in conjunction with full banded orthodontic appliances to help support the anchorage of the posterior teeth. The Facebow applies a distal force to the first permanent molars and the posterior teeth in the maxillary dental arch, while the anterior teeth of the full banded patient are aligned and or retracted as needed. A third use, in certain mixed dentition treatment procedures, the Facebow is also used. The type of treatment is called growth guidance therapy, and in the mixed dentition, distal forces applied to the first permanent molars sometimes can avert the development of a class 2 malocclusion. The first step in the construction of the Facebow appliance is the fitting of the maxillary first molar bands. After the bands have been fitted, into the patient's mouth. They're removed, and the procedure of spot welding on the buccal tube is performed. This is the buccal tube, and it is to be attached to the buccal surface of the first permanent molar band, centered mesiodistally and occlusal gingivally. Now, this procedure of spot welding is done with a machine designed specifically for that purpose, the spot welder, orthodontic spot welder. Several dental companies manufacture these spot welders. All of them operate on the principle of electrical resistance heating of two small areas of metal to the point where they will fuse or weld together. A dial is provided on the machine to regulate the intensity of the heat that's produced in the welding process. The intensity is 1 through 4 on this particular machine. For the welding procedure, the buccal tube is positioned, centered on the labial surface, buccal surface of that first molar band. And by pushing down on this bracket at the base of the machine, the jaws of the electrode are opened and the band can be placed in between with the bracket positioned exactly where you want it. You set the dial at a setting of 1 and press this lever on the side. The weld was just made. This procedure is called tack welding. It tacks the tube into position so you can inspect it and see if it's where you want it to be, see if it's centered properly. If you find you don't like the position, you can easily break that tube off with just finger pressure. And then it can be repositioned again and welded to place. We'll reposition it, place it back between the electrodes. And this time I'm going to use a higher setting, a setting of 3 on this machine to produce a greater heat. And the first weld is made. Check to make sure you've got that tube, that bracket, centered the way you want it on the buccal surface, and then proceed to make 2 more welds, at least 2 welds on every tab of the buccal tube. Occasionally it's necessary to squeeze the 2 electrodes together to make sure there's a firm contact of the 2 pieces of metal, that is the band and the tab of the buccal tube that you're welding in place. Now, when the tubes have been welded onto the buccal surface of both of the first permanent molar bands, the bands are then ready to be cemented into the patient's mouth. After the bands have been cemented in place in the patient's mouth, you then begin to adapt the Facebow. I'm going to adapt the Facebow to this plaster model as a demonstration. Usually the Facebow is adapted directly into the patient's mouth. This will allow you to see the adaptation better, more easily. I want to point out the fact that on our model we have a double buccal tube. There are 2 tubes. One is round, and that's formed to accept the inner bow of the Facebow. The other one next to it is rectangular, and it's intended to accept a edgewise orthodontic wire. The type of tube we're using now in the clinic involves only the round 0.045 diameter buccal tube. A little simpler design, a little newer design. The Facebows themselves come from the factory, from the manufacturer, preformed in this configuration. They consist of an inner bow, an outer bow, and a large solder joint joining the 2 sections. You start the fabrication or the adaptation of the Facebow by making a small scratch mark in the middle of the solder joint between the inner and outer bow. This scratch mark is intended to serve as a reminder which side of the Facebow goes in the superior direction, that is, towards the patient's upper lip. The bird beak pliers, the 139 pliers, are used to adapt the Facebow, the inner bow of the Facebow. During this adaptation, you have to be sure to keep the wire well up into the beaks of the plier to prevent damage to the delicate ends of the 139 plier. You start by contouring the inner bow of the Facebow to the same configuration as the anterior teeth. You should try it against the labial surfaces and then see what bends you need to make. An opening bend is going to be needed at the beginning. The inner bow is placed well up into the 139 pliers, and using the plier as a vise, an outward pressure is applied to open up the inner bow. This is done on the other side in the same manner, using the flat base portion of the plier as the vise for this procedure. The inner bow of the Facebow now adapts reasonably closely to the labial surfaces of the incisor teeth. You want to keep the solder joint of the Facebow centered on the central incisor teeth during this bending procedure. To adapt to the cuspid bicuspid region, a bend is going to have to be made in this area of the inner bow of the Facebow in order to sweep it around the arch. You can use a white China marking pencil to mark the wire on the spot where you want this next bend to be made. The beaks of the plier are placed perhaps a little bit distal to that mark, well up into the base portion of the plier, and you apply the needed force to bend that doubled portion of the inner bow of that Facebow. The same type of bend is made on the other side. And you try the wire back on your model. You want to end up with the inner bow of the Facebow 5 to 6 millimeters away from the labial surface of the incisor teeth and the cuspid teeth, and about 2 or 3 millimeters away from the labial surface of the bicuspid teeth. Sometimes some adjustment bends are needed at this point to bring these distal extensions in or out. This one seems to fit fairly well. With the solder joint centered, you mark the spot on the inner bow where the mesial edge of that buccal tube intersects the inner bow of the Facebow, on one side only. And you're going to fabricate what is known as a bayonet bend. The bayonet bend is the stop that prevents the inner bow of the Facebow from sliding right on through the tube. It's made first by placing the beaks of the plier right on the mark that you've made on the wire, and use your finger and make an inward bend in the inner bow. You place the beaks of the plier as far up in to the first bend as possible, with this time with the round beak to the outside, and apply pressure to complete the bayonet bend. You try the wire back on the model to see if your bend was made at the proper angle. You can sight down over the top of the model and see whether the bend you've made is in fact parallel to the buccal tube on the first molar band. I think a little adjustment bend would be needed here to bring the distal end of this inner wire more parallel. Now at this point you can mark the wire at the distal end of that buccal tube and cut off the excess. You try the wire into the buccal tube, slide it into place. It's a very precision fit, very tight, which is what you want in the patient's mouth. Now, it appears to me that a little adjustment bend to bring this solder joint more over towards the center of the arch would be needed. You remove the wire from the tube and make the necessary bend. At the bayonet bend is where you make this adjustment bend. I'm going to increase the angle between the little tab that sticks out the end and the rest of the wire. Try it back in the tube, and I think it's positioned properly now. That is the solder joint in relationship to the anterior teeth. You mark the spot on the other side of the arch just at the mesial of the buccal tube, and you make the second bayonet bend in exactly the same manner by placing the plier beaks at the mark and make an inward bend first, a lingual bend, and then place the beaks as far up into that first bend as possible, this time with the round beak to the outside, and make the second bend. Use your thumb to push the wire around the round beak of the plier. Going to sharpen up the first bend on that bayonet bend again. I think it needs to be a little larger. Now you can again sight down on the model without even placing it in the tube that you've already formed or in the tab that you've already formed to see how it fits. I think that a little adjustment bend again at the bayonet bend area in an outward direction will provide what we need. Try the wire into the tube, the side that you've already formed completely, and see how it rests in relationship to the buccal tube on the opposite side of the arch. It should be parallel to that buccal tube from a side view and also from an occlusal view. You can mark the wire at this point where it would extend beyond the buccal tube and cut off the excess. Try placing the wire into the tube now and check the relationship on the other side of the arch. Now, you can see that the inner bow here on this side sweeps upward in relationship to the buccal tube. It's not parallel exactly to the buccal tube. So some adjustment bend has to be made. We have to be sure that this wire is passive as it rests in the buccal tube. In this case, a bend in the apical direction is needed to adjust this wire for passiveness. Try it back on the model. And see how it relates again to the other side. Now, what we want to end up with is the wire parallel. And we have this wire parallel now, both from a buccal view and also from an occlusal view. The wire can be placed in the buccal tube on both sides of the arch, and the adaptation of the Facebow is then completed. In the completed adapted Facebow, there should be 5 to 6 millimeters of space between the inner bow and the labial surface of the teeth from the cuspid to the cuspid. The inner bow should sweep inward as it extends distally to be perhaps 2 or 3 millimeters away from the labial surface of the bicuspid teeth. The bayonet bends should be small. They should be confined to perhaps 1/8 of an inch of the wire only. The wire should be symmetric too. The solder joint centered in front of the central incisor teeth. It has to be a symmetrically bent wire in order to apply symmetric forces to the first molars. The wire, of course, also has to be passive. And you check for passiveness by seeing the relationship of the buccal tube to the end of the wire, with one side inserted in place and the other side free, resting on top of the tube. After the Facebow itself is adapted, the neck strap is then constructed. The neck strap consists of a piece of stripping that is elasticized with some small hooks to engage the outer bow of the Facebow. The elastic stripping and the foam rubber neck pads come in separate pieces. Here in our clinic, they have to be threaded through this foam rubber neck pad and the ends have to be formed. To form the end of this elastic strap, it is bent over so that the flap is to the outside, that is away from the foam rubber surface of the neck strap, and a stapler is used to secure the two pieces of elastic stripping together. Be sure that the staple is applied so that the continuous side of the staple wire would be towards the patient's neck. We want to be sure that these little ends do not scratch the patient. Usually 2 or 3 staples are needed at each end to secure the tabs. To adjust the length of this elastic stripping in a patient's mouth, you place the Facebow in the patient's mouth, Facebow in place, the neck strap engaged on one side of the arch, and on the other side of the arch we want to be sure that there is perhaps 1 inch of pull, 1 inch of elasticized pull between the hook and the little ring here on the end of this elastic stripping. That 1 inch of difference between the passive length of this stripping and the outer hook will apply approximately 1 pound of pressure. 300 to 400 grams is what is desired in terms of force level to move first permanent molars distally for most cases. After you've adjusted this length, the second staples are placed and the Facebow itself has been constructed. The second type of Facebow appliance, the high pull Facebow, utilizes a head cap made of straps. This head cap that fits over the top and back of the patient's head also comes pre-formed from the factory in this configuration here. Small elastic bands are used to apply the force to the first molars through the Facebow. These elastic bands hook onto little hooks on the strapping, and these are stretched downward to engage the outer hooks of the Facebow itself. And distal force then can be applied. Again, 300 to 400 grams per side of force is usually needed to produce the desired tooth movement. Now, in actual clinical usage, patients wear these Facebow appliances from 12 to 14 hours a day. Usually this involves after supper and while sleeping at night. This will usually produce the amount of tooth movement that we want. When the Facebow appliance has been constructed properly and when it's worn as directed by the patient, it can certainly produce very rapid and dramatic tooth movement.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.